Outside of a clinical trial, Ben, do you use maintenance?
I do. I mean, I think we have to keep in mind that despite the excitement for all these driver mutations, the large majority of our patients don't fit into those into the population that can receive targeted therapy, and we have to default for now to chemotherapy. And I offer my patients maintenance. My go-to regimen is generally 4 cycles of carboplatin pimatrexid, and if they've achieved at least stable disease and they're tolerating therapy, I will offer them single-agent maintenance pimatrexid.
Paramount approach.
Based on the paramount approach and based on the survival advantage that was demonstrated. Pimatrexid has now had 2 studies, the JMIN and the Paramount, one with switch and continuation maintenance respectively, that show both a PFS and overall survival advantage. So based on those studies, I do offer maintenance pimatrexid.
But one of the major arguments has been the absence of a mandatory crossover in the control arms of those trials to the study drug.
Right.
Unlike the Phidias trial, which looked at some called the immediate second line, but really maintenance therapy with docetaxel and then true second line therapy with docetaxel, these trials did not automatically feature true second-line therapy with pemetrexed.
And I think it should be pointed out on the Phidias trial that those patients that either got immediate docetaxel or actually got delayed docetaxel had no difference in survival, suggesting
But
it's
there
not...
was an attrition, 40% never
absolutely,
made it
yes.
to
So
second-line.
it suggests is not when you get the drug, it's if you get the drug.
And I think that's an important point. I think unfortunately we can't predict when the functional decline and disease progression is going to take place with our patients.
It can be precipitous.
Yes, so I think because of that, I try to offer maintenance up front. And the studies have their flaws. We do not have an early versus delayed pemetrexed study, but the studies we have are fairly convincing, at least in my mind. This drug is well tolerated, low emetogenic potential, and I think that because of that...
Probably one of the best tolerated drugs we have in our cytotoxic armamentarium.
Yeah, absolutely. So based on these studies, I will offer my patient a maintenance regimen.
Mark, your viewpoints on this, maintenance or no maintenance? And if it is maintenance, do you just continue the original regimen?
To me, it's the biggest no-brainer in oncology. And to put it in perspective, remember, you're only talking about a small number of people. It's people where you have determined that they have had objective benefit from this drug. You have also determined that this drug is safe. You have also turned to the patient and said, Mrs. Jones, is this drug been good for you? Does it inhibit your lifestyle or not? If the answer to all 3 of those is yes, it's good, why would you ever stop the drug? And to prove that continuing the drug works, we have Paramount, Avapril, Point Break, and ECOG saying continuing therapy in that patient. Now, please remember, we're talking, what, 15% of patients at this point?
Probably more.
Okay, 25 maybe. But we're not talking about everybody. We're talking about a very, very specific patient.
Well, Mark, in the trials that have been done, it's usually about 60% of patients who start with first-line therapy go on to get the maintenance.
Yeah. In Saturn, it was under 50, actually.
That's
in
true.
Atlas, it was about 60 because they got
And
it.
Avapril was 2/3.
Yeah.
It was
But
66%.
again, it's a small number of patients. But all things have to be true. All the stars align. You say it works. You say it's safe. The patient says, Doc, this makes sense to me. My life is good because of this regimen. I would never stop it.
Right, and I think that, it really, to me, I think you're right. This is a duration of treatment question. And how many drugs are you going to continue for how long? And we know that there are some drugs, like PEM, that can go a long time and people tolerate them. There are other drugs, like the taxanes, where we have much more...
You actually did a critical trial of that, looking at 4 cycles versus indefinite
platinums have pretty tough cumulative toxicity.
Yeah,
so it's tough to maintain them on that.
But you ask that question every visit, and if it's, Doc, I can't use my keyboard, you're done.
Exactly.
We'd like to get before that, though, and I think that's the...
Well, yeah, that's what they call the art of oncology.
Yes, thank you,
like
Mark.
Talking
Thank
to the patient.